thrombotic phenomenon in the venous system will be captured by the pulmonary arteries. Unfortunately, it's one of the main causes of chest pain. One of the serious causes. It's not main cause. It's not actually that common. It's different in different populations. But the symptoms are very varied, and that's what makes it difficult to diagnose. And the diagnostic test is complicated to do, the definitive test, the gold standard test. So that's why it's often talked about, and we'll talk about that specifically. So the most common reason for pulmonary embolism is thromboembolic events, which is DVTs, or abnormal blood clot itself. So we use those interchangeably, but you can embolize other things. Other things we see that you can embolize the pulmonary system is like fat embolism, which we see that in trauma patients, large bone fracture. We see that maybe in sickle cell. Amniotic fluid embolisms, we also see that in pregnancy and peripartum. We see tumor embolism like renal cell carcinoma. The actual tumor material is going to embolize into the lungs. We see air embolism. This is in divers. We see it iatrogenically in hospitals and medical care facility when central lines, etc., or IVs are not managed well. We see it in IV drug users. They can inject other things that can embolize, but obviously. So a lot of things can be embolized, but the majority is obviously primary thromboembolic events or from deep vein thrombosis. So what are the risk factors for PE? Well, if you think about risk factors, the question is really what are the risk factors for DVT? Because they're the same thing. They're essentially the same disease at different stages. So what are the risk factors for DVT? And the question is, what makes your blood clot abnormally is the question. So if you go back to physiology, we'll find this gentleman, Virchow, and he described that blood will clot abnormally under three circumstances. If the flow of the blood is turbulent, if there's stasis, if the blood is not moving, or if there's something abnormal within the heart, within the blood itself, when it becomes hypercoagulable. So you have to consider these three things when you think about what are the risk factors for thromboembolic events. When it comes to disease, we talk about risk factors, and these risk factors are important to ask about and consider when you're seeing a patient, or you're considering the diagnosis. So if they're obese, they have metabolic syndrome, they're smokers, they're hypertensive, all these things increase the risk factor for thromboembolic events. Then there's non-modifiable things that increases with age, increases on things that malignancy, obviously recent surgery, trauma, etc., infection. All these things increase your chances. COVID was, for example, was specifically associated with increased thromboembolic events. It had a very high rate, and that's probably due to infection itself and something specific within how this infection caused disease. We see it in places with more pollution. We see it in people who go on long-haul air flights. We don't know the exact mechanism of why that happens, but people who do long-haul flights or even long-haul driving for long periods of time will develop it. OCPs and estrogens per se are increased your risk for thromboembolic events. And then foreign bodies, if you have again, which will make the blood flow turbulent, ICDs, pacemakers, etc. Vascular, like dialysis lines, from a cat, anything that's in the vessel will increase your chances of pouring thrombus. And then if you have, obviously, again, if your blood itself is at risk for increased thrombosis due to abnormal factors such as protein C or S deficiency, or abnormal proteins such as antiphospholipid antibody, which increases thrombosis risk, or antithrombin deficiency, which is decreases the chance of breaking down blood clots. So what are the symptoms and signs of a PE? Well, the symptoms and signs are very varied. The classic was a description of chest pain that's pleuritic in nature with shortness of breath happens, but it's quite uncommon. I think less than 30% of patients have these symptoms. So often they'll come in with other non-specific symptoms, with just dyspnea. Some patients will come in with just maybe some non-specific chest discomfort, and some patients will come in with just cardiac arrest. And it's one of the presentations of cardiac arrest in a young patient, who's healthy. Prior to that, it just comes in suddenly and their heart has stopped. We think about PEs in these patients quite often. Some patients come in with wheezing. Some patients come in with, ischemic-like symptoms of chest pain that seems ischemic, but turns out to be a PE. So it's difficult based on the symptoms best. The signs are also quite variable. The most common sign is tachycardia. It's unexplained, but sometimes they may not have tachycardia. They can be just tachypnic. Some of them have low-grade fever. Some of them have abnormal heart sounds. And, less than 30% of them will have obvious signs of a DVT, even though the most common cause is a DVT, as I described. And some of them may have hemoptysis. So blood testing is often important in these patients because the blood testing, in essence, is used to rule out other causes of chest pain. Most of the patients with PEs will have normal blood testing, and you won't have any cleaning. If someone has shortness of breath and tachycardia, and then you do a CBC and his hemoglobin is 5, then you have an explanation. That's probably why he's having these symptoms. Or if he has a chest pain that's pleuritic, but his troponin is 1,000, then you probably have a diagnosis then. For the blood testing helps you look for causes, of these symptoms. You've all heard of a D-dimer, right? Do you know what the D-dimer is? Assuming you're still with me, does anyone know what the D-dimer is?
I'm not sure, but is it something we test for to see if there are any ischemic changes in
Mohamed منكم heard of a D-dimer? Interesting. Into which years? 5th year? 6th year? أي سنة؟
we're seniors, doctor.
Yeah, which year? I don't know what senior means.
Last year.
Yeah.
6.
And none of you knows what a D-dimer is?
Okay.
And I have an idea. I've heard of it at least, and you don't need to be correct, or at least have some concept of what it is. Have you heard of this test? It's a blood test. Yeah, somebody wrote blood test. Okay, good. Sure, but other than blood test, it's not meaningful. Have you heard of this blood test? Anyone? No?
Yes, doctor.
Okay, yeah. I'm assuming you have. People have. It's mentioned in so many places in your textbooks. Do you know how it works? Do you know what it measures? No. Okay. I'm surprised because other groups have a better understanding. I'm sure half of you are asleep. That's what part of it, or not present, and then the other half, I don't know what their excuse is. Anyway, so D-dimer it measures fibrin degradation. So it doesn't actually measure blood clots. There's no such thing as something that measures a blood clot. It doesn't make sense. In hemostasis and in your coagulation cascade that you studied, the last part of the factor 1 is fibrin. And when you put fibrin, that solidifies the blood clot, that makes it hard. But so how do you get rid of fibrin? Well, you break it down. It breaks down. And then the breakdown of fibrin can be measured itself. The amount of broken fibrin is D-dimer. It's fibrin degradation, basically. So it gives you an idea about fibrin being broken down. So it doesn't tell you that you have a blood clot. It just tells you that we're breaking down fibrin. So the problem with this test is that it's good and it's very sensitive. So it tells you that if there's any fibrin in your body that's being broken, that's very good. 95% of the time, it'll tell you there's fibrin being broken. But it's not specific. And fibrin degradation can be high in patients normally, for people with many reasons, with chronic diseases, even normally in normal population. 40% of people have a high D-dimer at baseline. So it's not specific. It's sensitive, but not specific. And I think that's important to understand, which is why we talk about negative predictive value. And it's been validated. This test is useful for patients in the emergency department and in the outpatient setting, but it's not been validated to use in an inpatient setting. The patient in hospital for 5-6 days for pneumonia, you don't measuring their D-dimer that's not where it's been tested. It's been tested in the emergency department, primary healthcare, and if it's negative, it's highly suggestive that there's no abnormal thrombosis in the patient. But if it's positive, it doesn't tell you much. It doesn't tell you that they have a thrombus. It just says, we can't rule out the thrombus of this patient. That's all that it means. Does that make sense? The explanation of how it works, positive and negative? You're not getting any validation for it. Does that make sense? Because I'm not going to explain this point, and it's definitely going to come in the exam. So it better make sense to you guys, or it doesn't have to, and you just get answer wrong. Anyways. Okay. So D-dimer is an important part of assessing patients with a concern for thromboembolic disease. So EKG. EKG is again important because people with chest pain, shortness of breath, or cardiorespiratory symptoms need EKGs to look for precipitating causes. Obviously, ischemia, arrhythmias, all these things can give you the symptoms. So the most common findings you'll find in patients with a PE is sinus tachycardia, which is just fast heart rate. There are some findings more suggestive, such as right bundle branch block, right heart strain. There's a very specific finding, which is an S1Q3T3. It's a very specific finding and very highly suggestive of an acute pulmonary embolism. But it's rare. You see it, I think, in 10 or 15% of patients. So if you don't see it, doesn't tell you they don't have the disease, but if you see it, you should be highly concerned. And it's often people will ask about it in exams. And it also can come in with acute arrhythmias as well. Or it could be completely normal. You still have a PE. Just keep that in mind. So it's important to understand the constellation. Chest X-ray. Generally, in people with pulmonary embolism, the chest X-ray should show you nothing. Should be completely normal. Because if you come in with pleuritic chest pain and a cough, and then you have a pneumothorax, well, then I know you don't have a PE. You have a pneumothorax on the chest X-ray, or you have a pneumonia. Then the pneumonia is probably the cause, or a hemothorax, etc. But it helps you look for. It tells you other causes. But if the chest X-ray is normal and the blood testing is normal, then you have to assume that maybe there is an acute cause, such as a PE. There are specific findings that suggest a PE on X-ray, on imaging. One of them is like a Westmark sign, which is where you can't see the pulmonary vasculature anymore. That's quite rare to see. And the other one is the Hampton hump, which is like a pizza shape, infiltrate in the lung, and that suggests that there's ischemia of the indicated pulmonary infarction of the actual lung itself. These are very rare things to see, but they like asking about them in exam. Mostly the X-ray would be normal. So what's the gold standard? The gold standard is the definitive test. And that's a big problem with pulmonary embolism, that the gold standard is not an easy test to do. It's a CT pulmonary angiography. It's basically a CT timed at the pulmonary artery. So when the right ventricle, ejects, it's going to fill the pulmonary arteries. That is the way to diagnose a PE. That's the only really definitive way to diagnose this. And it looks at all the vessels. It's good because it definitely rules in the disease. It tells you if you have disease, and it looks for other causes that you're not obvious on other imaging modalities, such as pneumonia, atelectasis, pneumothorax. Sometimes you can miss those. So not only does it tell you that the disease exists, it tells you about the severity, it tells you how big the blood clots are, and also can tell you about the function of the heart. Is the heart dilated or not? So it can tell you if this is acute or chronic, because some emboli are chronic. It can also good because if you do a venous phase, if you wait till the contrast comes back, you can actually look at the veins and look at look for DVTs in these patients. And like I said, it can tell you about the severity of the size of the clots, the number of the clots, and the heart function itself. So this is just an imaging, and I'll show you this what a CT pulmonary angiography looks like. So this is the aorta here. You can see my mic. Oh, can you see my pointer or my two-phone pointer? Okay, so this is the aorta, and this is the pulmonary arteries here. So this is the contrast coming in. So here you see the contrast abruptly stopping. This is the left pulmonary artery thrombus. It's a large thrombus. It's very proximal. It's not one of the small arteries. And then this is the same. A few images down, this is the same heart. So this heart, this is the right, this is the left side. The right heart is supposed to be smaller than the left heart by 30%. But here, clearly, it's bigger than the same size or bigger than the left. So this heart's dilating. So this right ventricle is struggling to pump the blood and starting to expand because it can't pump blood. And then here's another small. This is what a small blood clot would look like here. So this is a pretty severe pulmonary embolism, diagnosed as CT pulmonary angiography. The other word they use it for is called a spiral CT. You might read that in some textbooks, spiral CT, or CT pulmonary angiography. It's not the same as a CT chest with contrast, because CT chest with contrast can look for a different arteries. It can be used to look at the aorta. CT chest with contrast can be looked at the other pulmonary arteries. So it's just so spiral CT or CT pulmonary angiography is the specific test you want to look at the pulmonary arteries for PE. Other tests we can use to help us diagnose PEs is DVTs. So if looking for a DVT. So if you have chest pain, shortness of breath, and you have calf swelling, and I do an ultrasound on your leg, and I see a DVT, then I don't need to do a CT of your chest, because almost certainly your symptoms are due to PE, and the treatment is the same. The CT then might be helpful to say how serious is the disease, but it's not necessary. Other tests you may hear of is a VQ scan. It's called the ventilation perfusion scan also. It's a radioisotope scan where they get get RBCs, and they get they get blood, and they put the radioisotope label on it, and then they get radioisotope and they put it in the air you breathe, and then they get a scan of you and they see where is the isotope reaching. So if there's a part in your lungs where there's air reaching with the isotope, but there's no blood, then that tells us that there's no blood going to that area. And that's called a VQ perfusion, or mismatch. So that tells us there's a blood clot there. So it's important to know about. It's still used, not often, especially used to be used in pregnant patients who are high risk for PEs, because they thought there was less radiation to the mother and the fetus. But now it turns out that's probably not the case. But it's still used, so you need to know that it exists. Another thing we can do is a conventional pulmonary angiography. Before we had CTs, we did what's called conventional angiography, which is what interventional radiologists do. They put the contrast inside the pulmonary artery and they start shooting it and do x-rays. And then that's both diagnostic and therapeutic because they can try to pull out the clots that way, and they can see how extensive the clots are. And then other things we do contrast venography, like I said, with the CT, where they look at the venous phase, look for the DVTs. Differential diagnosis for pulmonary embolisms is quite large. It can be very serious things and very benign things. Anything from things like costochondritis, anxiety, pleurisy, like post-viral URTI, musculoskeletal pain of the chest, pneumonia, bronchitis. All these things will cause these symptoms, right? It can be more serious things like myocardial infarction, dissection, pericarditis, heart failure, pulmonary hypertension. All these things can cause shortness of breath, chest pain, palpitations. So that's the problem with the PEs, is that it can be quite vague and difficult to diagnose and can be quite deadly. So that's why we have scoring systems. The scoring systems are systems used to help us know who should we test and how should we test them. That's the point of them. But you have to consider diagnosis. So if you have someone who has like you have a pneumothorax, then I wouldn't apply the scoring system because you have a clear explanation. But if someone has a constellation of respiratory cardiac symptoms and you don't know the cause and you're thinking PE is the possibility, then these are the patients who appropriately apply a scoring system to. There's many scoring systems. The most common one you see for study is the Wells scoring system. It's an American scoring system. And it basically, it's a dichotomous system. It puts you into two categories, high risk or low risk patients. And if you're a low risk patient, based on this criteria, then we do a D-dimer for you. And if the D-dimer is negative, then we ruled out the disease. But if you're a high-risk patient, then we don't do a D-dimer. We just do the gold standard CT pulmonary angiography. Why? Because if you're high risk, then we think that the D-dimer, even if it's negative, is not enough. Because like I said, the sensitivity of the D-dimer is 95%. So 5% of patients will have pulmonary embolism or DVT, and the image and the D-dimer is still going to be negative. So you can't 100% say they don't have the disease on the D-dimer. But if you're low risk, already you have low risk factors, and then we get the D-dimer, and we do D-dimer and it's negative, then we'll believe that test because it's very unlikely that you will have. Does that make sense?
Yes.
Okay, because people find this very confusing because it's the Wells rule is a rule to help us decide: do you need a D-dimer or not, or should you just go for a CT if you're considering a PE? That's what it's used for. Okay, and if you look at the components, there are obviously risk factors for PE or DVT that are highly suggestive of the disease. So if you have a DVT, if you have symptoms of a DVT, and then you have no diagnosis other than PE that you can consider, and they're tachycardic, and they've been immobilized, and they're having hemoptysis, and they have cancer, and then you do a D-dimer and it's negative, I don't think you're going to believe that patient doesn't have a PE, because it doesn't make sense, right? You're going to say, no, I'm sure he has the disease. He has all the findings that are highly suggestive of this disease. So I needed to get the CT, to make sure he doesn't have the disease. But if he has none of these risk factors, let's say he's very low risk, he has none of these risk factors, but you don't know why he's having chest pain or shortness of breath. And you say, I'll do a D-dimer. If it's negative, then, there's 95% chance, I'm sure. And he doesn't have any risk factors, so I'm almost 100% sure he doesn't have the disease. So that's how that works, okay? There are other rules like the Geneva score, same concept. We just don't use it as often. You just need to know it exists. And then there's this rule you may see for thought as well. It's called the PERC score. We use that in combination with the Wills score, this one. The PERC score is an additional test because the problem with even the Wells score, even when you're low risk, it still leads to a lot of false positives. You still end up sending a lot of D dimers, and a lot of D dimers come back positive because, like I said, 40% of people have high D dimers at baseline. So you'll get a lot of, and if you have a positive D dimer, the only way you can confirm that there's no disease is to get a CT pulmonary angiography. That's a lot of CTs. So in a way to increase getting more CTs, we developed the PERC rule. The PERC rule, if somebody is low risk wells and you're considering sending a D dimer, then you can do the PERC rule. And if the PERC rule is negative, then you can say that this patient's risk is so low that he doesn't even deserve a D dimer. And I can clinically rule it out without doing this test. Does that make sense?
Yes, clear.
Yes, doctor.
Okay. So disease severity. So PEs come in different severities. You know, some of them are small clots like we saw, and some of them are very large clots like we saw. So they can come in with, and we kind of categorize them into three risks. Three. There's different ways of categorizing it. The main one is massive pulmonary embolism is classic one, or you know, there's different ways of classifying them. And there's submassive, and then there's more, and then PE in general. Massive PE is a PE that's going to kill you or has killed you already. So it's a PE that causes shock or cardiac arrest. So if it causes hypotension, hyperperfusion, or causes cardiac arrest, then it's a massive PE. Submassive PEs are PEs that don't cause cardiac arrest or shock, but cause organ dysfunction. So the PEs that causes dysfunction in the organs where you become, you know, like the organs are suffering. So what does that look like? Well, they cause increased troponin elevation because your heart is working very hard. They cause increased BNP because there's a lot of pressure in your heart. They cause abnormalities on echo because your heart's working very hard to pump against them. They cause significant hypoxia because there's a lot of burden in the lungs. So they're, and these PEs are important to know because if you have a submassive PE, there's a good chance, a good proportion of them become a massive PE. So these PEs need to be admitted to hospital and may need even monitoring, need to go to the ICU. So in case they do get worse. So that's why you need to know this diagnose submassive PE versus massive. And then we have small to moderate PEs, or most PEs are just traditionally called PEs. So most patients with PEs actually just have symptoms and have no organ dysfunction. And these is, in that sense, is mostly benign in that sense. The PE itself is not likely going to harm them, but it's the another PE that may kill them down the line. That's why we need to treat this disease and find out what the cause is. So these patients even can go home, and there's a lot of evidence that these PEs can be treated and sent home. And those, they don't have any organ dysfunction. Their heart function is normal. Their troponins are normal. They're not hypoxic, and usually they're not comorbid because obviously someone who has like chronic lung disease, heart failure, and gets a PE is much likely to do way worse than someone who's healthy and young. So how can we classify the severity of PE or the risk of deterioration of PE? Well, there's many classification scores. It's just one. The SPESI is the one most common. They use and just tells you this is a high risk PE and you probably should keep this patient in the hospital or even admit him to the ICU. So the PE itself can cause local complications. Not common, but sometimes it can cause pulmonary infarction, chronic pleuritic chest pain. It can cause some fevers with that. Usually it gets better with time. Not really a serious thing, just something to know about. And again, like I said, PEs can be, if we go back to the virtuous triad of why people have them, then we think about things that are reversible and things that are not reversible, provoked and unprovoked. And that's a big category of PE and DVT. Is this provoked or unprovoked? If it's a provoked DVT, then we remove the provoking factor and we treat it. And if it's unprovoked, then we can't fix it. Then we have to anticoagulate the patient so it doesn't happen again. So how do we treat PEs if you have an acute PE? Well, you need to anticoagulate the patient. It's important to understand that anticoagulation doesn't actually break down blood clots. It just thins the blood so it doesn't happen again and doesn't get worse. Anticoagulation prevents progression of disease and recurrence. It does not treat the disease. The only way to break down a blood clot in your body actively is your body usually breaks it down. That's the fibrin breakdown. Your body will break down blood clots. Now, we do have a medication that can bust clots, thrombolytics. We use them in strokes. We use them in MI, right? TPA, you've heard of the TPA, right? Smato and TPA, ولا ما سمعت TPA؟
ما سمعنا عنه.
ما تعرف stroke والheart attack ما تعرفون how people treat those? حاجة جلطة حاجة سكتة قلبية. or how do you treat that?
TIA, doctor?
لا, a stroke, not a TIA, an actual stroke. And جلطة, he's hemiparetic, he can't move. He has a thrombus and he's MCA. How do you treat that? What do you do with that?
ABC.
No, how do you fix the blood clot? There's a clot. في جلطة براسه قاعدة. Oh, he has a heart attack. And just STEMI. ST elevate. Okay, so what's thrombolytics? Which is the main thrombolytics? What's the what's the medication called?
Heparin?
Thrombolytics. Nah?
Heparin?
No, not at all. Not at all. Heparin is definitely not a thrombolytic. Heparin is an anticoagulant. Thrombolytics are... Nope. Aspirin is an antiplatelet medication.
The clot.
Yeah, well, okay, sure. What's the medication? It does dissolve the clot. It thrombolizes the clot. It breaks it down. What's the medication? Have you heard of any medications that break down clots?
اللي plays هدول.
Yes, something. Alteplase, good. Tenecteplase, Ritaplase. There's many, TPA, whatever. It's all the same thing. كلها, these are thrombolytics. They break down blood clots. Heparin thins the blood. Blood unlikely to clot, very difficult to clot because it prevents clotting. Aspirin, Plavix, هذه أشياء antiplatelets. It prevents platelet function. They work very differently, and it's important at this level. If you don't know the difference between these medications, I'll tell you that. Other groups definitely know, and I've taught a lot of other groups, and they know the differences at least. Maybe they don't know the name of the medication, but it's you need to ask yourself why I don't know this at this point. It's a problem because you need to know these medications. And it's very fair game. We're going to ask you which medication, what's the function of it. You need to know. So heparins are medications that basically prevent progression of blood clots. We use them to prevent blood clots from getting worse or happening again. They can be given, the heparins are given in an IV or subcutaneous form usually. The common thing is unfractionated heparin. It's given as infusion, and you can monitor it with PTTs. Then there's low molecular weight heparins, اللي هي injection site and if you have surgery or etc. to prevent blood clots from happening. If you have orthopedic surgery, or these you give it to. And they can also be used, again, if you have a P or DVT, they prevent the progression of disease. And then thrombolytics are if you have a massive P, if you have a big P that's going to kill you, and you need to break down the clot, then you give it TPA, TNK. هذه الأشياء will break down blood clots actively. It will attack the blood clot. But the problem is that it causes, its biggest side effect, it causes severe bleeding. So if you have it can cause a GI bleed, a triple bleed can kill you. And we give them for acute strokes, and we give them for MIs as well. If you don't have a PCI, لما عندكم محل ما في قسطرة, we'll give them thrombolytics. So it's quite commonly used. There's no place for antiplatelets in blood clots in PE or DVT because they don't. That's different. That's for cardiovascular disease, for strokes and heart attacks and ACS. Now, more recently, what we use is, instead of heparins, we used to use, warfarin. Telephone warfarin, صح?
Yes.
Okay, so warfarin again thins the blood, زي heparins. It works on vitamin K, so it works on multiple different parts of your clotting cascade to make the blood more thin and less likely to clot. But it's taken as an oral medication. But recently now we have multiple new medications called DOACs, direct oral anticoagulants. And these medications are superior to warfarin. They thin your blood, but they don't have so many interactions. You don't need to monitor it. You don't need to check INRs اللي هي monitoring حق warfarin. And they will thin your blood. And they work very quickly. They don't need an admission. You don't need to admit the patient to give them the medication. With warfarin, you have to, because warfarin needs what's called bridging. You need to give them anticoagulation until the warfarin works. It takes about 3 to 4 days till it works. Whereas DOACs don't. They work within 6 to 8 hours. There's multiple DOACs, Roxaban, Apixaban. You've heard of these before, I'm sure.
Yes.
Yeah. So these are important. These are used to treat DVTs and PEs. They're also used in other things such as cardiomyopathy or left ventricular thrombus. But the most common reason they're used for is DVTs and pulmonary embolisms. And now they even use them prophylactically. يعني احترازيا زي low molecular weight heparins post surgery, etc. They will give you this medication for a few days because it works prevent formation of blood clots. If you're in a hospital and they will use something like I said, unfractionated heparin, which is an infusion. The good thing about unfractionated heparin is that you can turn it off. يشتغل هو الحالة حقه 4 ساعات. If I put you on heparin, then you bleed because you have a GI bleed or whatever, then I can turn it off and I can reverse it, even have reversal. The problem with the DOACs هذه كلها, and it's very difficult to reverse. الhalf-life حقها مرة طويل. So if you start bleeding, I can't stop the bleeding. Low molecular weight heparins is long-acting but very effective and subcutaneous, 12 hours, but requires an injection. Is quite painful but very effective. And the thrombolytics, the alteplase, being the most one people use, is used only for massive PEs because the risk of bleeding is very high with these medications. They break down blood clots. So you wouldn't give this for a small PE. You wouldn't even give it for a moderate PE. You give it for a large PE that's going to kill you because the risk-benefit. Does that make sense?
Yeah, doctor.
هذا أيوة.
Sorry? One person.
أي واحد اللي أعطيه للماسك PE.
A thrombolytics, دكتورة. Alteplase. Okay. You can go back and read the slides. At the end of the day, I think there's a lot of core concepts that you need to understand. I'm not going to explain them to you. You need to know the difference between these medications and why. So, like I said, PE DVTs can happen from provoked or unprovoked things. If it's provoked, انت كسرت رجلك, لبست cast, بعدين جتك جلطة بعدها because you can't move your leg, etc. This is provoked. Remove the cast. You're not at risk to have this again. So generally, the anticoagulation duration is 3 months. So into further like especially for women, if you smoke and you take oral contraceptives, one of the biggest risk factors is you're going to get a DVT or PE. So if you get one, we tell you we want to remove the provoking agent, either the estrogens or the smoking, then you're unlikely to have this again. So we anticoagulate for 3 months. But if you have like protein C, protein S, antiphospholipid antibody, this is genetic. You can't fix this. So you need to go on anticoagulation for life. So it depends on the cause. If you have cancer, we treat the cancer is in remission. Your risk of DVTs becomes the same as the population, so you don't need it. But if you still have the cancer, you still need to be anticoagulated. So IVC filters. I think it's important you know what it is because I'm sure you've never heard of it. Some patients have DVTs and PEs, but you can't anticoagulate them. خاصة المرضى اللي يعني إصابات متعددة دخل حادث سيارة وجت له كسور ونزيف في الرأس and then he's قاعد في السرير, he's immobilized وعنده كسور. So they are high risk for having blood clots. So these patients, you can't put them on a blood thinner because they're bleed. Like they have bleeding, they have a subdural, epidural, or someone has a GI bleed and has a DVT. It happens pretty often in medicine. What we do is we put an IVC filter. This is a filter in the inferior vena cava. So in theory, this is supposed to catch blood clots moving from the veins of the legs into the right heart. Does that make sense? Can you imagine how this works?
Yeah, I think, doctor.
Yeah. So like I said, almost all PEs come from DVTs. The DVTs are in the lower extremities. They detach and they fold into the right heart. So if you put something in the IVC, which is the area of blood where the blood is coming from the legs, you put this filter, it can catch the blood clot. It's not been proven to improve mortality, but it definitely decreases the burden of PE. So if you have a contraindication to anticoagulation and you have a DVT, this is an indication for an IVC filter. You just need to know why it exists and you can remove it. It's retrievable now. So you think about PE or DVT if you have someone with cardiorespiratory symptoms and especially unremarkable chest X-ray that can't explain the symptoms. Thrombolytics such as TPA or alteplase is only for massive PEs because it's risk-benefit. IVC filters are used only in patients who can't anticoagulate, ما تقدر تعطي مخثر للدم, but they have a DVT, so those are the patients who put the IVC filter for. Most patients now with PEs can be treated with oral anticoagulants. They're sent home. The workup why they have it is done as an outpatient. That's it for my talk. It's a lot of information, a lot of content. Do you have any questions about the PE talk?
No,
Thank you, doctor.
That's clear, doctor.
Okay. عموما, if you have any questions, reach out to me by email. I don't respond to WhatsApp messages. Don't do that. Yeah. Allah يوفقكم. And I think there's a lot of things that are يعني ما أعرف هل هو لأنكم online وما أنتم مهتمين or not interested. I can't tell, but I can say that a lot of the stuff other groups do know that you don't know or no one is able to speak up about. I just, you need to be aware of yourself. And you're not at this, and if this is the level of interaction, there's a problem. But I think you should read the slides. These are important topics. Majority of the exam حكيتي من أشياء زي كذا. Okay. الله يوفقكم.
Yeah, thanks, doctor. But
يعطيك
I
العافية
think
دكتور.
because it's online, that's why.